Good morning and welcome to the Caregiver Teleconnection. My name is Glenda Rogers and I'm going to be your host for today's session. This is the second in our series of Engaging Caregivers, a program for healthcare workers. And today we're going to be talking to Dr. Elliot Montgomery Sklar and Lucy Barylak, and we're going to talk about difficult situations and elder abuse. Not an easy subject, but one that's very important. So before they get started, let me tell you just a little bit about Lucy and Elliot. Lucy Barylak has a master's degree in social work from McGill University. She is presently working as a consultant for a health network in Montreal, Canada. She has been involved in various research projects and has published numerous articles related to caregiving issues. She has lectured at several universities and colleges on innovative approaches to caregiving and presents annually at international and national conferences. Lucy is also a consultant for private industry in the United States, including her work with the WellMed Charitable Foundation and clinics in Texas. She would also like you to know that she was a caregiver for her mother for about 10 years. Dr. Elliot Montgomery Sklar is an associate professor of health science at Nova Southeastern University in Florida. He has worked as an educator, researcher, and leader of community-based health programs in the United States and Canada for over 15 years. He has a doctorate degree in public health and teaches disease outbreak and investigation, which has been central to the COVID-19 pandemic. Since the pandemic began, he's helped to facilitate over 75 sessions to support caregivers during this time for the WellMed Charitable Foundation, the American Public Health Association, and for senior living communities across the country. Welcome, Lucy and Elliot. We're so glad you're with us today.
Thank you.
Thank you.
So good morning, everybody, and thank you so much for joining us for our second session. Let's look at the learning objectives for today. We're going to discuss difficult behaviors and how to handle them. We're going to define advocacy in the content of patient care. We're going to recognize signs of elder abuse and how to help, and examine conflict in patient care and the role of communication. So before I start, I just want to really say that I feel very strongly that there's always a good reason for a person displaying difficult behaviors. It could be mental health issues, could be dementia, could be pain, loss of control, anger, frustration, depression. The key is to find out what is the problem and what triggered that behavior and how to deal with it. So, let's talk about what are difficult behaviors, especially when a loved one suffers from any form of dementia. So here are some examples of difficult behaviors. They're agitated, there's mood swings, being forgetful, repeating themselves over and over again, aggression, both verbally and physically, mood swings, refusing help with activities of daily living, being sexually aggressive and using inappropriate language, being paranoid, accusing the caregiver and others, or delusional, seeing things that are not there, and also wandering. So there's a lot more, but these are sort of the basic ones that we see very often when a loved one, especially with dementia. So let's look at what impacts could there be on the caregivers. Caregivers don't know how to respond in many times, especially if the behavior is completely out of character and unexpected. Caregivers may feel helpless, frustrated, they get angry, desperate, confused, or hurt. So coping with difficult behaviors can make an already challenging caregiving situation even more complicated. And in many cases, I want to say that it can even cause, it could lead to verbal and physical abuse from both sides. So this is sort of a quick little scenario of what caregivers may be going through when their loved ones are displaying difficult behaviors. So let's look at some tips that would be helpful, and some tips that you could share with your caregivers. So first of all, if it's a new situation or not, they need to make an appointment with their doctor's loved one as soon as possible. The person may have a new medical problem, such as a urinary tract infection, that is actually affecting them both physically and mentally. They may have started a new medication or even over-the-counter medication that is having a side effect. For example, they can become more confused, they're sleepy, they're dizzy, not able to walk. So these things have to be checked out. Try to understand what triggers the behavior. Are there any patterns? Are there situations that could be avoided? So what do I mean by that? For example, if you see the loved one is all of a sudden getting very stressed and agitated, it could be noise that's coming from the TV, from the radio, from outside. They may have passed a mirror and saw their own reflection but couldn't recognize it and became very agitated and afraid. So first and foremost, it's always good to acknowledge and validate their loved one's frustration. Don't argue or confront them. Okay, simply understand. So for example, if you feel that they're afraid, you can always say, you look scared, you look worried. Don't worry, I'm here for you. Reassurance is extremely important. It's also important to maintain familiar routine as much as possible to instill a sense of security. Keep things simple and try to stay within a daily routine that they are either remembering or sort of knowing. It depends on their cognitive functioning at that time. So the other thing is try to distract and redirect the person. All right, so if you see that they're extremely agitated, they're angry, do something different with them. Try playing some music, going for a walk, ask them if they would like to have a snack, a gentle hug. And sometimes even removing them from the room helps a lot. So staying calm, don't reprimand, use a tone that's reassuring. I think caregivers need to know to be patient, that it's not easy to be patient, but in the long run, it will really reassure their loved one and give caregivers a sense of some control over the situation. Now, the other thing, caregivers should always have a plan in place if the behavior sort of gets out of control. So what I mean by that is to have a plan, meaning that they should write down names of people that they can call that can come over right away. And the worst case scenario is to call 911 and for them to realize that calling 911 is important, that if the person becomes very aggressive, they can hurt themselves and they can hurt their loved one as well. So I was just wondering, can anyone share an example of how you dealt with difficult patients' behavior? Do you have any new suggestions for us today? Love to hear from you.
So you just need to raise your hand, put something in the chat box. If you dialed in on your telephone, you can unmute pressing *6, and I will call on you that way. Oh. Elliot, you and I were duplicating our efforts there. Anyone have an example of something like this? Refusing meds, Karen says. That's a good one, common one.
Okay, so how does is there a question or is it something that the person went through?
Oh, it's a daily situation. My sister calls from Canada. We live in Colorado, and it's just a daily process of coaxing medication taking. And I'll just add on to this. She does have caregivers in the home, and she refuses, her showers twice a week. And it's like, she'll say she'll do it with her husband later. She'll put it off as long as possible. Usually I'll call and say it's shower day, and stay on the phone until she gets in the shower with her caregiver, and you try to give options and choices, like, well, would you rather have a sponge bath or a shower? The love and logic way. But yeah, this is explaining that, and then how important is it that she get a shower twice a week or once a week, or that kind of thing.
That's a very good point that you're making. It's true. If they're not doing anything, or they're not going out that much, it's how often should they be showering? But I want to just go back to the medication part. One of the best people that can help you out is a pharmacist. Now, to try and ask them, I know that some caregivers that I dealt with, and I'm sure you've maybe practiced that, not that you want to deceive anybody, but if it's really important for them to take their medication, it's maybe to put it in certain foods. Never cut the medication. Always ask the pharmacist first. As far as bathing, I mean, I do a whole series on the activities of daily living. It's part of the routine. It should be part of something looking forward to. For example, making sure that the bathroom is warm, that there are nice fluffy towels, that maybe some music is there. It takes a lot of time and a lot of effort. But thank you so much for sharing that with us.
Anyone else have a situation they'd like to share? Okay, I guess we can move forward.
Sure.
All right. The music, I think, Lucy, was a good tip. Sometimes people like to have some music with them in the shower or the bathroom, or even to sing with the person that's helping them bathe. It can be a good distraction if that's a source of comfort.
And I'll just add that actually is what one of the caregivers does, and my mother loves to sing, and so putting the music on and making it fun and pre-warming the bathroom, they definitely do that to make it more fun. So thanks for that.
No, it for sure. I mean, it's difficult. One caregiver she had a very fluffy bathrobe that when the person saw that, it represented like a really nice time in their mind with the music and a nice warm bathroom with proper lighting. Yes, all these little things. You have to know your loved one. It takes time, but it's in the long run, it's worth it.
Yeah. Thank you.
So I think, while it's critical to know how to handle difficult patient behaviors, there are also other difficult situations that healthcare workers can encounter when working with patients and caregivers. Our healthcare systems can be unhealthy if you think about it. And I think that only adds at times to tensions between patients, caregivers, and healthcare workers. Simple things like long wait times in clinics, which have been pervasive through the pandemic, or waiting for home care, for example, which again has been very challenging because of staffing shortages. Consecutive appointments being canceled or rescheduled, which again has happened quite often, or even delays to previous appointments. Essentially, anything that may have gone wrong in the patient pathway can potentially lead to a challenging interaction between patients, caregivers, and healthcare workers. So as healthcare workers, we can often face the frustration. We can be the face of frustration, rather, for patients and caregivers, especially when we consider the health status of certain older adults whose health conditions are only deteriorating and not improving, such is the case with Alzheimer's disease, for example, despite our very best efforts to help. So there are many challenging interactions that can occur daily. And these challenging interactions may arise due to discrepancies in expectation, perception, and sometimes also communication between the patient, caregiver, and healthcare worker. So sometimes difficult situations arise when a patient or caregiver, for example, has done research online about their ailments and is convinced by their findings of a conclusion. They might demand certain investigations or treatments, and you might not be the appropriate party for whom they are voicing that to, as an example. There was a health system actually here in the United States that had an amazing marketing campaign. They had billboards along major highways that said, "Please Google your symptoms." And it was an advertisement to drive people to their emergency rooms that was actually very effective. Because often when we Google our symptoms, we're rather alarmed by what comes up. There are also sometimes difficult situations that can arise when people feel that they're not being listened to. And I'm sure we all know how that feels and how frustrating that can feel. But it can also become threatening, to a person when you're talking about a health condition. Sometimes we have patients that are in denial and also don't want to accept a doctor's diagnosis or counsel, which makes it then very, very difficult to help them adhere to a treatment plan. There are other times when symptoms are affecting quality of life and there's just simply no clear-cut diagnosis despite thorough workups and so on. And again, I think some of us have been there at certain points and we know how very frustrating that can feel. And we question also the competence of the healthcare workers that are serving us. There's sometimes also frustration with non-compliance between patients and caregivers. So I think it's important to acknowledge these things because it's important in terms of helping to prevent and also to resolve challenging interactions. We really need to consider that these things might be contributing to difficult situations. And there's a lot of variability in the development of also appropriate communication skills among healthcare workers. Many of us have found that we're working with patient communities that we might not have had a lot of experience with. And that can be a challenge as well. There's, an inherent issue that occurs when there's a lack of communication skill training, and that can often occur. I'm a healthcare educator, and I firmly believe we don't spend enough time educating our healthcare professionals on communication skills. So inappropriate choices of words and phrases, perhaps due to assumptions being made about the patient's level of health literacy or understanding of their health, can certainly be one of the outcomes of that lack of communication training. Perhaps a lack of options being offered to the patient and caregiver, and that happens a lot. Not involving the patient in the decision-making process. For example, when treatment decisions are taken without involving them, and without addressing their needs and wishes, not referring to the patient to appropriate support services or resources. And sometimes that's just because we don't know where to refer patients. But it's very important that we help to be a conduit in making sure that we're giving them access to all the things that they might need for their health and wellness. So I think it's important to break down information into small pieces that are easy to understand and to ensure that the patient and the caregiver have a clear understanding of what is being communicated. Asking patients to reiterate and confirm halfway through the conversation, also to summarize at the end, helps to ensure that both parties understand the same information and action plans. So as an example, if you're providing counseling information, behavioral health counseling, you can then ask the patient and the caregiver to repeat to you what they understood that you explained. And that can be helpful to making sure that both of you are on the same page. So I think it's really important during any interaction to consider the role of the patient's caregiver. We know that a lot of healthcare education is very patient-focused, patient-centered, but caregivers are a critical part of that person's support and care team. Caregivers may also have their own questions or concerns about a specific condition or how to manage it, which should certainly be addressed. Now, the inclusion of a caregiver is essential, especially in a bad news conversation. 2 pairs of ears are always better than 1. That's why we usually tell people to bring someone with you to a doctor's appointment or to write things down. It can be really hard to take in information that might be difficult, unexpected, or even difficult to understand. And so it's very important that you make sure that people really understand what you're trying to convey and that you do so in a sensitive manner. Nonverbal communication is equally as important as the actual words. Because for example, if I was sitting with my arms crossed, that wouldn't make for very open two-way communication. So body posture, gestures, eye contact, they can all combine with verbal communication to facilitate a meaningful, positive communication between patients and caregivers. And I think that's especially true for people with any kind of a cognitive issue, because when you look them in the eye, that's very, very important and powerful. So the thing that I think most people universally have in common, especially since COVID, is that we are anxious about healthcare. And more research is coming out about how COVID has made people more anxious about their healthcare and about receiving healthcare. So I think it's important that we sort of acknowledge this right now. It's something that I've seen in healthcare environments. I recently went for a physical, and I really noticed that people around me seemed a little bit more anxious than usual. And of course, I was anxious because I was at my doctor's. But you know, there are ways to further access information and support. And some patients may also not take in all of the information if they're feeling very anxious when you're working with them. So I think it's really important to reassure patients and caregivers, again, that it's a very good idea to write things down, whether it's at the time of a consultation or if they have a list of questions ahead of meeting with the doctor, for example. For a great example is if you're a home healthcare worker and you notice that something is off, make sure that you note to the caregiver and patient that they should write down next time they see their doctor to ask about certain whatever it might be. I think it's also important that we look for signs of anger or distress or increased speed of speech. That's a really key sign of anxiety or a change in behavior or body language. This is a good one, and it's important then to divert, distract, and occupy. So asking people questions like, what did you have for lunch? What are you having for dinner? Are you making that yourself? Are you going to a restaurant? And you just keep asking questions. That can help to really actually change a person's thinking. It was a practice that a doctor used with me once. I had been extremely anxious at an urgent care appointment, and my blood pressure was very high. And the doctor kept asking me questions about what I had for breakfast and what I was eating that day. And I thought that they were trying to link my blood pressure being elevated or my anxiety to maybe having had too much caffeine or something. But it was actually just a way of distracting me, and it was very, very effective. I think it's also important to build connections and to find common ground to reassure the patient that they can feel safe and can communicate openly. For example, sometimes when I'm anxious going to a doctor's office and a nurse will say, I feel the same way when I come for my physical, that can be helpful. So help your patients and caregivers try to get some level of emotional control over the anxiety that might surround health. Feeling helpless and hopeless is a common challenge encountered, I think, by patients and caregivers facing difficult health conditions or health news. So imagine being a patient yourself. Not being in control can trigger negative emotions and can make communication difficult. Empathy and effective listening help with this. Also, keeping the patient and the caregiver informed and involving them at each step gives them a sense of control in the process too.
Thank you for that. Okay, we're going to talk now about elder abuse. So let's look at that. So obviously it's physical abuse, inflicting pain or injury, such as slapping, hitting, brushing, restraining. It could also include inflicting medication tampering, giving too much or withholding medication. When we talk about elder abuse, it could be sexual abuse, any non-consensual sexual contact, whether comprehended or not. Then there's the emotional abuse, inflicting mental anguish or distress through verbal or nonverbal acts, threatening, intimidating, and humiliating the person. Now, neglect also is a form of abuse and also self-neglect. So it's really important to keep that in mind, that even if they don't have a caregiver and if they're not taking care of themselves, it is self-neglect. Failure to provide food, clothing, shelter, healthcare, or protection. The other one is financial abuse. illegal use, misuse, or concealment of funds, property, assets, or benefit for someone else's gain. So you're actually robbing that individual. And then there's abandonment abuse, desertion of a vulnerable adult. So these are all the categories when we talk about elder abuse that we feel are very important to keep in mind. You know, it's interesting, but very, very hard to accept that elder abuse or the intentional physical or psychological form of neglect of seniors is shockingly common. 1 in 10 adults experience elder abuse or mistreatment, according to the National Elder Mistreatment Study conducted by the National Institute of Justice in June 2020. And I think that it's even more than 10. I think it's probably maybe 1 in 7. The majority of senior abuse victims are females, where the majority of the perpetrators are male, according to the American Psychological Association. And adult children are the most responsible of elder abuse, followed by spouses, partners, and other family members. And the abuse of elderly in hospitals, long-term care homes, and nursing home is also a concern despite strict regulations. So I kind of want to elaborate a little bit more about the signs of abuse. So I know I sort of a little bit said it, but let's get a little bit more specific. Obviously, there could be bruising, there could be cuts, abrasions, burns, and other physical signs of trauma. The person could become a little bit more confused, they're depressed, or sudden social withdrawal. They're not really interested to do the things they did before. Their financial situation has changed. They don't seem to have the funds to be able to support themselves. Bed sores, poor hygiene, weight loss, unexpected negative reactions to physical contact. That means they don't want you to touch them. They sort of body language like, stay away from me. Unexplained venereal disease or injury to private areas. Self-doubt, unwillingness to speak. Some actually stop speaking. So if you see any of these signs, it may or may not be abuse. And this is what I want to emphasize a little bit. It could be a medication. For example, if they're on Coumadin, they could easily bruise. However, if you notice any of these signs, you still need to ask the caregiver what has happened. Don't blame, but get the facts. You may need to report your findings, and we'll talk a little bit more about that. It is important to keep in mind that a loved one may be abusing the caregiver. If you see any signs of abuse on the caregiver, you need to gently find out what's going on. Sometimes caregivers are reluctant or embarrassed to tell you. As well, seniors who are abused by family members or even friends don't want to get their family members or friends in trouble, so they don't talk about it. So I guess you have to be very, very vigilant and really try to get to the bottom. If you see any of these signs of a person's changing, and one of them, as I said before, the whole idea behind it is that their personality has somewhat changed, and you can actually see physical signs.
Now, the impact by healthcare professionals in recognizing and reporting elder abuse and obtaining resources for those mistreated can be profound. Healthcare workers have different perspectives on their role in the detection and reporting of elder abuse. In a lot of different research studies, nurses tended to perceive elder abuse as uncommon and generally did not feel it was their role, nor did they have the time to assess patients for potential abuse. Physicians, on the other hand, felt that other patient care issues, time limitation, and maintaining trust in the clinician-patient relationship outweighed the importance of detecting and pursuing suspected cases of elder abuse. And they relied upon social workers to approach these issues with patients. Social workers, although having the most knowledge and experience related to elder abuse, relied upon nurses and physicians to detect potential abusive situations and to work with them when making appropriate referrals. While social workers were perceived by all groups as having a major role in reporting elder abuse, social workers reported major obstacles to reporting and achieving adequate results within our current systems. All of the groups of healthcare professionals acknowledged the need for more and better education about elder abuse detection and reporting. Now, it is possible that such education could be helpful in providing a better base of knowledge for people to address both assessment and interpretation of elder abuse. I think giving healthcare workers the tool to better assess patients for elder abuse in the short amount of time that they have may begin to address practicality problems. While not as obvious as physical ailments, elder abuse is much more prevalent and impactful on health than most healthcare workers recognize. So a common question that people ask is how to report elder abuse or abuse of an older person or senior. Now, you can call the police or 911 immediately if you know that someone is in immediate life-threatening danger. But with elder abuse, that's often not the case. So if the danger is not immediate, but you suspect that the abuse has occurred or is occurring, it's really important to tell someone. Find out what the protocol is within the agency for whom you're working or the community in which you're working, and find out if there are tools for assessment of abuse or if there's an internal protocol that you should be following for wherever it is that you're working. You can relay your concerns to the local adult protective services, long-term care ombudsman, or to a local police precinct. You can also most easily reach the elder care locator by phone, and we have that number here for you. It's 1-800-677-1116. You don't need to worry about jotting any of this down. We will send out our copy of our slides after our session today for everyone who has registered. Now, the elder care locator is open Monday through Friday from 9 a.m. to 8 p.m. And they have specifically trained operators that can refer you to local agencies that can help. The laws in most states require helping professions in the front lines, like doctors and home health care providers, to report suspected abuse or neglect. These professionals are called mandated reporters. Under the laws of 8 states, any person is required to report a suspicion of mistreatment, but that's only 8 states. These reporting mandates vary widely between states, and most states do have some level of mandatory reporting laws, but they are inconsistent. So we've provided, again, some links here that can help provide some more information, because obviously we could do a whole series on elder abuse and how to detect and report it. I thought this would be a good time, though, for us to pause and see if anyone had any questions or any comments that they wanted to make.
All right. If you phoned in, you can press *6 on your telephone. That will unmute your phone, and I'll call on you. For those on Zoom, you can just unmute your phone. I'll be able to see that. Or you can post a question or a comment in the chat box, and we'll read that so that the people on the telephone can also hear that.
Always on the same thinking, Glenda. That was why I read the phone number, even though it was visible to people.
Exactly. Why do you imagine, Elliot, that it's so different in different states about this reporting, since it's such a key issue, being able to safely report? I know here in Texas, you can do it even online and just type in a message about elder abuse.
Well, just like Medicaid functions differently in different states, for example, reporting is different in different states. I wish that there was some federal provision so that things were a bit more consistent, especially with the number of professionals that we've recently had relocating from one part of the country to another. I think this is an especially important issue because people might not be familiar with the reporting laws or the policies or practices where they might be.
Yeah. I know at the Area Agency on Aging that I worked in here in Texas, we were definitely mandated to report. So I appreciated that. It makes you feel more comfortable to do it when you know that it is required of you. so that you don't leave any doubt that, you know, well, maybe I don't, but yes, you do. So, yeah. Can you discuss inappropriate sexual behaviors of a client toward their caregiver? This is Karen again, and I've heard about these situations also.
Yes, I mean, I do a whole series on inappropriate sexual behavior. You know, we have to take into consideration, and I'm not generalizing, but a lot of times when people do have a form of dementia, you know, their thinking patterns, they don't remember, they don't know. So their behavior comes across as inappropriate because of the disease more than anything else. Now, I had a caregiver send me, she actually emailed me. It was a daughter who had a very close relationship with her father who had dementia. And the last time she went to visit, she sort of got up to say goodbye. And her dad, you know, hugged her and started kissing her, and not like you would kiss a daughter. And you could just very well imagine how she felt at that time. So, you know, inappropriate sexual behavior is really showing inappropriate affection, like trying to kiss your daughter in a certain way, touching other people, touching themselves as well, masturbating in front of people, removing their clothes, using foul language. I mean, almost to the point when it really, really gets bad. I've had some caregiver wives and partners that have basically told me I'm getting raped every night, or trying to be raped every night by the person that I loved. So it's a very, very delicate situation that needs a very understanding person to intervene, not to blame, not to judge, but to really try to get down to what is actually going on. And many times it's important to, not many times, I would say all the time, it's important to get in touch with the loved one's doctor and to let them know what is actually going on. Now, keep in mind that sometimes certain medication can trigger sexual behaviors as well. And there are medications that could also kind of calm the person down a little bit. It's not a quick fix, but the caregiver needs to know that someone is there and are able to talk about it, because for a lot of them and for a lot of us, it's an embarrassing situation to be in. So, you know, it's just making sure that if someone is going through that, is to be there for them and to be supportive. Kind of a long answer, but I kind of wanted to get everything in. So I hope I've answered it. You know, are there any other questions around difficult behaviors, and any questions about elder abuse that you would like to ask or share with us what you've gone through?
You can simply unmute your phone. We'd love to hear from you.
I'd like to know if your presentation on dealing with difficult behaviors or sexual behaviors in particular is available on the website or any other site.
Yes, it is. And I'll let Glenda tell you how to do that. I do repeat the sessions on our calendar, but it's been recorded. I think I did it not too long ago.
Thank you.
Yeah, you can just go to the website and you can type in Lucy's name and it'll bring up all of the sessions that she has done, and you can look for it there. Or you can type in the search also for that topic, and all of the sessions that have been done related to that topic will also, you know, pop up. If you have any problems with that, call our customer service representative, and I'll give you that number again. It's toll free at 866-390-6491. And
Thank
thanks
you.
for asking that question, Karen. That's important for us to reiterate that those are available to
Great.
everyone.
Thank you.
And keep your eyes out for coming calendars, because I know this is a very popular session for Lucy. In addition, you can email any specific questions that you have to the WellMed Charitable Foundation, and they're amazing at sourcing those questions over to us. Many of them get incorporated into the sessions we wind up then facilitating.
For sure. And if I get an email, I will answer it as well. So thank you for that. Okay, so if there aren't any other questions or comments, let's just move forward a little bit. You know, as Elliot reported, he was talking before, healthcare workers can be a great support to caregivers and clients when they see themselves as advocates. So let's talk about what is advocacy. I'm really, really big on advocacy, I have to tell you. So advocacy is defined as any action that speaks in favor of, recommends, argues for a cause, supports or defends, or pleads on behalf of others. Okay, so when healthcare workers advocate, they ensure that their clients and their caregivers are able to have their voices heard on issues that are important to them, protect and promote their rights, have their views and wishes genuinely considered when decisions are made about their lives, help navigate unfamiliar circumstances or difficult transitions. Now, as well as protect their confidentiality, that's really extremely important. Now, when I talk about have their views and wishes generally considered when decisions are made, I really feel strongly many times plans of intervention are made or services are provided, and we somehow don't take into consideration the wishes of the caregiver and of the client, not because we don't want to. Many times the agencies we work for are very strict in how they function and how they provide services. So healthcare workers should advocate by, first and foremost, we have to be good listeners, being non-judgmental, providing information and guidance, genuinely understanding caregivers and clients' concerns, exploring different options, having caregivers and clients think about the outcomes and consequences of decisions that are made for them or even decisions that they make for themselves. Respecting the caregiver's decision and the client's, helping caregivers and clients to communicate their thoughts, needs, and wishes. To access services as well. I think it's really very important. I'll give you an example of what actually happened to me when I was a frontline worker many, many, many years ago. For example, the caregiver was eligible to receive a few hours of respite services. And really her need was not in the day, but it was more in the evening. And in our policy at our agency, respite was only given in the day. It wasn't even thought about giving it in the evening. That might not be the case for you. So I really had to advocate and argue that in order to help the caregiver and the care receiver, she needed those services in the later kind of afternoon, early evening, when it was difficult to put this gentleman to get him ready to go to bed, sundowning, whatever it was. And so I had to kind of really advocate and challenge the service and say, why not? Why can we not do it? Now, it's not an easy thing to do, but at the end of the day, when you advocate, it should meet the needs of the caregiver and the client and not the need of the agency. So if it didn't really have any, it's the same money. It was just trying to find a different way of handling the situation. The other thing is when you're advocating, when you're an advocate, when you're making referrals, you should be advocating for the best possible results to meet the needs that the caregiver and the client has identified. Many times organizations, agencies are very strict in the services that they can provide. But, we have to be able to challenge it because advocacy is part of changing service delivery to meet the specific needs of individuals, as well as speaking out for those who cannot speak for themselves. So we have a really, really important role to play. And I know it's not always easy to advocate because you're kind of challenging, but if you come with good arguments and you find solutions, then many times it can be accepted as well. So I want to really open this up because I love to talk about advocacy. Can anyone share an example of how you advocated for your client or for your loved one for that matter? And what were the results?
So just unmute your phone, or if you are on your, I said unmute your phone. If you're on your phone, press *6 to unmute it. And those of you on Zoom can just unmute your phone and we'll be able to see that. Karen asked a question about accessing Lucy and Elliot's emails. And so I'm imagining as I look at Elliot, he is typing something in there. So how would y'all like to address that?
In the past, whenever people have emailed the foundation at the general email address, those emails get sourced to us. So that would be my best suggestion. You can also certainly look Lucy and I up online. You can find us, but the foundation will certainly connect you to us.
And I'll type that email address in the chat box for you. And before we hang up, for those that are on the phone, I'll also share that with you.
And definitely, if I get an email, I will definitely answer it.
Advocacy, that's a good topic. Anyone have an example of being an advocate for a client that perhaps, or a caregiver that you've served, and how it turned out? Sometimes they don't turn out the way we think they should, right, Lucy?
Oh, absolutely. And it's a very delicate, it's very delicate to be an advocate, especially in an agency, especially when you're the worker and you're kind of questioning how things are done. But there are ways to do it. There are really ways to do it. And I think frontline workers are the key. You know exactly what's going on. You're the ones that are right there dealing with caregivers and clients.
Exactly. And I loved your example that you gave. Since I was the director of the Area Agency on Aging, my frontline workers came to me often with somewhat unusual requests. But then when I looked at it and realized that they were advocating for that person they were trying to help, it took down a lot of those policy barriers that we can bend and shape to help clients. So I was glad you gave that example. Well, okay, everybody is still, oh, there we go. Yes.
I don't know. It was more of a question.
Okay.
Especially when you're working in an agency setting, you find yourself advocating a lot. You go in, you do home assessments, you see that the client has needs. So, obviously you're going to advocate for those needs. But I don't know if you do a series or
We're having trouble hearing you, Michelle.
without giving too many details. I have a client.
I think
I'm so sorry. Can you hear me now?
Yes, that's a little better. Thank you.
I didn't hear
Okay.
the question.
In a situation where you have a client that you are trying to advocate for, but the client does not necessarily want the assistance. Like, for instance, I have a homebound, bedbound client, lives alone. There's many safety issues. We've contacted APS, we've done everything, but because, he is of sound, mind and able, according to his doctor, to make medical decisions for himself, we're in constant fear. What is there any information that you can provide when you're in a situation where you know that a person needs help, you want to advocate for them, but they're refusing? So then what do you do then?
Very good question. At the end of the day, as long as a person is still considered competent and able to make these decisions for themselves, many times our hands are tied. We cannot make choices for people unless you can prove that their behavior is putting themselves totally at risk. But it's very, very hard when a person is still competent to make those decisions. I think the best way to work with someone like that is to get their trust and to listen to what they're saying and sort of slowly developing that trust and putting in a little bit examples of how things could be made better for them. But at the end of the day, unless Elliot, you want to add to this, I'm talking from the perspective of Canada, where I'm coming from. A person has a right, as long as they're competent, to make a decision for themselves, even though we see that that decision could be put them at risk. What are your thoughts, Elliot, on that?
Yeah, I echo what you said. Unfortunately, the same holds true here in the United States. So long as a person is deemed competent, they are in control of decisions that they make about their healthcare. And that can be very, very frustrating for healthcare workers. So I offer two suggestions. You can take a harm reduction approach. If there are specific things that you're concerned about with this specific client, focus most on the harms that you're concerned about and how those can be reduced. So if it's that the person is bedbound and not moving around, maybe they might be open to having some stretching or movement exercises or someone helping them with that. Just an idea. The other is also motivational interviewing. And we could do a whole session on that, but that is a technique that you can look up. It's extremely, extremely successful when used with people who present with difficult behaviors or who are resistant to changing behavior. And motivational interviewing makes it a process of two-way communication between the patient and the provider to engage them in decision-making about their own health, but in a way that helps you achieve the goal that you are trying to in moving that person toward accepting help and treatment. So it's used very commonly with tobacco cessation as an example, with homeless healthcare, but it's a very, very successful and helpful technique.
Thank you.
Of course. I am mindful of our time, so I'm going to just quickly run through the rest of our presentation and then open it up for some last questions and comments. What we wanted to share was that there are state resources in each state through the Aging Services Division that is dedicated to providing frail seniors with home and community-based services so that they can continue living in their homes instead of having to enter a nursing home. That doesn't always happen, but the provision of that is there. And we do have some links there for you. But in addition to these programs that help seniors directly, many states also offer caregiver assistance programs that provide family caregivers with information, counseling, and respite. So my suggestion is to always reach out to your local area agencies on aging whenever there is a concern of elder abuse or neglect, or if you're trying to connect your clients with some of these services. The Ombudsman is another resource, and the Long-Term Care Ombudsman is a statewide office that exists under the Older Americans Act. So it is through a federal program. This does exist in each state, and the Office of the Ombudsman has the responsibility to investigate and resolve complaints about quality of care in long-term facilities, including nursing homes, assisted living, board and home care, specialty care facilities, and even dementia daycare programs. So we've provided there the link for you to access your long-term care ombudsman, but they can also be an excellent resource in helping you to advocate for your clients, your loved ones, as well as for helping to identify or troubleshoot or even mediate potential conflict or issues. Now, it's important to remember always that under the law, every long-term care resident has rights and protections, and they have to be given a copy of these rights. They're usually posted somewhere in the facility, and if you are in a facility and you don't see them, be sure to ask for them. That is well within your rights. There are additional resources that we have, such as the National Center on Elder Abuse website, which also offers additional information. And you can visit their website at ncea.acl.gov for those joining us by phone. If you have any concerns about assisted living or nursing care facilities. Now, next week during our program, the last in our series, we'll be focusing on the importance of cultural competence and sensitivity in healthcare environments, including long-term care. This session will also be focused on what professionals should know and consider. And as always, we have some resources that we'll be sharing with you all. Sorry, that was a really, really quick rundown, but I know that time is of the essence.
Ooh, yeah, it made my head spin. Would you talk about certificates of attendance, please?
Absolutely. So we did the website that was shared in the chat box. You can email if you participated in today's session to receive a certificate of attendance. You can receive another one for participating in our session on the 17th on cultural diversity and gender and sexuality.
So if you haven't registered, I really encourage you to go ahead and register for that last of this series. It will be a good one. For those of you on the phone, let me give you our website one more time so that you will have that. It's www.caregiverteleconnection, and that's all squished together, caregiverteleconnection.org. So you can go to that site. Somebody had asked about the Caregiver SOS program. You can find information also on that site or by calling our customer service representative, which I've given you that number before. Let me see, there's one session I wanted to mention that's going to be before the next session. Oh, all right. On Monday, March the 14th at 12 o'clock noon. And for those of you who are working, that might be a good time for you to tune in. We're going to have a presentation on Caregiver to Caregiver with Bill Southern and Dina Boyd, and this is sponsored by the North Central Texas Caregiver Teleconnection. It's going to be a panel discussion with caregivers, actual caregivers, so that might be of interest to you, and I encourage you to tune in. You will be receiving a follow-up email to this session, and we're going to be asking you for some feedback on how we did. And providing the information that Elliot and Lucy have presented here today. So watch for that. If for some reason you weren't registered for today's session, you can call our customer service representative and she will be sure that you get all of the resources information shared today. Lucy and Elliot, we have about a minute. Final words?
Well, just want to thank everybody for joining us, and I hope you join us in our next session, and be well and take care of yourselves.
Thank you, everyone. Stay well, and please complete your post-session surveys if you registered for our session. Thank you so much and hope to see you next week.
Bye-bye. Stay well.
Patty, thank you.
Bye.
Thank you.